telling you about the federal position on these overdose prevention sites, and that is to say, there is only a handful of people in the US doing research on these sites at the moment, but the research they're doing is quite robust. And researchers are potentially getting some signals that there is a change in the way that the feds are thinking about these things. And there's some openness to considering the data. So I think that's very encouraging. I'm going to present just a little bit of data locally. When Assemblyman Orentlicker approached us to start having conversations about what an overdose prevention site legislation could look like, Lisa and I seized the opportunity to do some data collection both in Reno and Las Vegas with people who use drugs to get their perspectives on what they would think about a place like this, because it is a priority of our research group to center the perspectives of those for whom interventions are delivered. So Lisa and I, in May 2021, did a series of qualitative interviews with people who use drugs that we recruited mostly through convenience sampling and street-based outreach. We asked them essentially, have you ever heard of an overdose prevention site? And what would you think about it? How would you like it to run? What do you see as the benefits? What are your concerns? And how, if we were to consider something like this in your community, how would you like it to be done? So this is just a quick table on this slide that shows you the demographics of the folks we were talking to. Important highlights. About 60% were unstably housed, reporting living in a park, street, abandoned house, or in their vehicle, but about a quarter were living in their own house or apartment. They were about 36 years old, a little bit more than half male, a quarter Hispanic, and just over 50% white. Next slide, please. We identified three big kind of overarching themes in the stories that people were telling us. People, when we asked them, what do you think about an overdose prevention site? How would you use it? What would be the benefits? What would be your concerns? People's opinions kind of grouped into three groups. They talked about benefits to self, they talked about benefits to others, and they talked more broadly about benefits to the community. So some of these things align with things I was talking about earlier in terms of opportunities to harmonize public health and criminal justice strategies. One of the biggest benefits that people perceived to their own selves from having an overdose prevention site in their community, someplace where they could go to use drugs under a supervised and clinically supervised environment, is that they wouldn't be at risk of criminal charges for carrying syringes. I don't know if I mentioned this on the slide where it was noted, but we are still hearing in Nevada reports of people being charged for carrying syringes, even though they should be protected under the paraphernalia law. They also saw benefits in terms of having another opportunity to access sterile supplies, to get help with other medical concerns like vein health, and to access referrals to appropriate services and care. On the right side are quotes. The numbers are participant IDs, and the Reno is that these interviews were done in Reno. And so this is people actually talking about what benefits they would see to themselves. And I want to draw your attention to the top one, because it kind of illustrates some of the themes that I was talking about earlier. This person said, I have people ask to come over. This is a housed person saying, I have people ask to come over here to my house to fix or get high. I don't want to let people do that, but I let people do it here because I don't want them to do it in the street. And that's problematic. I had one person overdose on me, which was frightening, and other people have requested to fix or get high here, and I tell them no. And I always feel bad, but I just can't risk it. It's probably how I got hepatitis. I was letting people fix at my place. So what you're hearing here is a person who has their own place, who is looking out for their friends and community members by allowing their friends to come over and use drugs in their house so that he can keep an eye on them and he can be there to respond if somebody overdoses. But that is a big burden on him. It's an emotional burden, and it does put him at risk for some very serious criminal justice sanctions. And so to this person, opening a site where he could send his friends, where they could get medical care, get linked to services, and not be in his home would be an enormous benefit that he sees to himself, but also to his friends for whom he is providing this informal service. Next, please. Other people, many people didn't think they would use the site themselves, but could see how this could benefit other people, keep people from having to do this stuff in public. It says in that first quote, it would be helpful. People are talking about self-managing their mental health system. So in the second quote on the right-hand side, it would definitely be helpful, because sometimes that's why we use is to get rid of depression and anxiety. Maybe that particular person might not need heroin. They might need an antidepressant or something. And it would be a window to a door for them to be able to walk into a space that would meet them where they are, allow them to do what they need to do, and provide the opportunity to link to clinical behavioral health care. There are unique issues to women who are using drugs, women who are living on the street, and women who are seeking services. So being a woman using drugs can increase vulnerability in certain ways. And so one of the things that people talked about was running a space where there would be women's nights so that women could come together and be protected from some of the things that they face, but also have opportunities to link to services and care. Next slide. And finally, people talked about benefits to the broader community. When we asked people what would be the benefit of opening a space like this, they talked about the ability of a space like this to reduce drug use in public spaces, to reduce discarded syringes, to reduce crime, and to reduce stress on EMS and emergency responders. So in the quotes to the right, oh, I see a lot of benefits. It would save the county money on overdoses because people could be treated there. When their immune system is not as robust and they're susceptible to endocarditis, which is the heart infection that I was talking about earlier. I mean, it would save the country a huge amount of money in hospital bills, I'm sure, because indigent people requiring emergency services and transportation and things of that nature would be receiving care inside. The next person says, it's reducing public exposure to some of the most tragic kind of results of drug use. The biggest thing for me personally is that you wouldn't walk up on somebody who had died or who was dying. And if they were just able to go to this place, that would happen less. The only place for that horrible stuff to happen is out on the street in public. Where are we going to go? I mean, we don't have a spot to go. It happens where it happens. So providing people a space to come inside, to be with other people, to be supervised, not only reduces the chances of overdose death, but also reduces public exposure. And I just want to point out one data point from the international research on these sites. Many overdoses happen in these overdose prevention sites, but not a single person has died from an overdose that they have experienced at an overdose prevention site. So the take home there is people might still be consuming drugs in such a way that depresses their respiration and sends them into an overdose. But because there is supervision and there's medical personnel on site, nobody has died in an overdose prevention site. Next slide. Okay, so I guess I get to wrap this up by talking a little bit about, the slide says gaps, but I think about this really more in terms of opportunities as we think about how to move things forward in the state and in the nation. As we've talked about, I think a fantastic opportunity that we have to consider is whether there is a space for overdose prevention sites in Nevada and how we could implement those in a way that could really address some of the drug-related harms that we continue to experience. The data are out there and they are strong, that there are many potential benefits of these sites, including cost savings, reducing burden on the hospital system, and decreasing fatalities. Nevada at the moment only has 2 syringe service programs, Track B that you heard from earlier and Change Point up here in the north. And even though Track B is expanding their services through harm reduction vending machines, this is really not enough to meet the needs of the state. One of the opportunities that we see moving forward is to really make sure, embracing these principles of harm reduction, that people who use drugs are engaged in the decision-making process as subject matter experts. when we are thinking about policies and programs and services to address drug-related harms, we need to be thinking about how to get the people for whom those services are intended in the room and at the table and amplify those voices. And we can also think about that in terms of funding allocation. It's not always the case that funding for programs ends up with the grassroots organizations who have the expertise and are doing the work. So making sure those grassroots groups are also getting to the table is an important opportunity moving forward. Next slide. Housing First initiatives is a bullet point here because, as you all know, in Nevada and in many places, housing affordability and housing instability is a major problem. And the link between housing instability and drug overdose death and drug-related harms is really, really tight. They are intimately connected. And so ensuring housing stability is a step towards reducing drug overdoses and reducing drug-related harms. And then finally, for a lot of today, you heard some really fantastic data. We have many surveillance systems set up in this state that are tracking drug-related harms in terms of morbidity and mortality. I would like to suggest that one of the opportunities we have is to complement those surveillance efforts with more granular analysis of the circumstances of deaths. We are counting deaths in our mortality and morbidity reports. But if we looked more closely at the circumstances surrounding death and what was going on in those cases, I think we could get a better handle on where to place our resources and where to place our interventions. You also heard a lot today about upstream interventions, and we have to be doing all of it. And investigating a death record is too late, but it could tell us where to intervene so it doesn't happen again. And again, I would emphasize that best practices in terms of harm reduction research suggest that even in our surveillance efforts, we incorporate the on-the-ground perspectives of people who are using drugs. And with that, I think I will end and we can take questions.
Thank you so much. So much information out there. I would entertain questions from the committee. I have Senator Doñate first. Please go ahead.
Thank you so much, Chair Peters. And of course, thank you, Dr. Wagner and Lisa, for your presentations today. I find this interesting because it's at the forefront of public health innovation. Dr. Wagner, would you be able to detail what has been the feedback that you have gained from law enforcement regarding these sites, and what is the substance of the conversations that you've had with them in terms of implementation since the session ended? Since the 81st session ended, I think that would be helpful for context for us.
Thank you for that question. Carla Wagner for the record. I can tell you a little bit about kind of what's happening in terms of how we're talking about these things. There might be other people in the room who could do a better job answering your question specifically about conversations we've had in the state. But what I can say is that you're asking about overdose prevention sites, right?
Correct.
Yeah. So this is another place where we have an opportunity to better harmonize criminal justice related concerns and public health related concerns. As Lisa pointed out, there are statutes at the federal level that make this difficult, and those are criminal justice related statutes. So addressing the crack house statute, which prohibits the intentional operation of a brick and mortar establishment where people knowingly use drugs, is an opportunity, right? Because on the law enforcement side, they're asked to enforce that standard. On the public health side, we're saying the public health value outweighs the enforcement need. The other concern, and I think the thing that needs to get resolved, is that there has to be some kind of buffer space around a place like this. One of the big concerns that people talked about when we asked them, what would you worry about if we opened a space like this, is how am I going to get to and from? If every law enforcement officer in the community knows that I'm going to this space to use drugs, they know that I'm going to be carrying drugs, there's going to be problems, they're going to stop me on my way in or out. So these are opportunities where we're really going to have some difficult conversations, but I think the idea that we are all moving in the same direction in terms of minimizing deaths needs to kind of be our central focus. think Lisa has some follow-up.
Senator Dunyate, thank you for the question. I myself have not had conversations with law enforcement since the 81st session, primarily because I wanted to hear what the people who use drugs for which these sites are intended for have to say and what their concerns are. Just because they're the ones that are dying. And so I definitely want to be mindful that if these spaces were to exist, they would be spaces in which the people who are intended to be there would actually come there. I'm not sure about law enforcement, but as Dr. Wagner mentioned, that was a concern that came up time and time again. Another concern, which I find most interesting, coming from the child welfare perspective, is that there were mothers who talked about their current practices of substance use now, that really, when you think about child safety, permanency, and well-being, they are legitimate concerns. And they talked about how spaces like this, they would eliminate having any kind of paraphernalia within their home, and they wouldn't have drugs in their home because they would bring it to the site, use there, never have that stuff around their children. And then the other concern that they expressed living with was the fear of overdosing in the home and having their child find them and what that would be like, and not having the courage to have the conversation with their child around how to use naloxone, right? That is a very uncomfortable conversation. And so I think those are legitimate concerns, and those were the things I picked up on coming from the child welfare perspective. And so I wanted to bring that up in this forum.
Thank you so much for that insight, Ms. Lee and Dr. Wagner. Really appreciate the work you guys have put in on this particular issue. I would encourage folks who are interested in this topic to reach out to and work with Assemblyman Ornlicker, as he has continued interest in this particular area. And we can see what we can do as we go into the next legislative session. Assemblywoman Titus, I saw you turn your camera on. Do you have a comment or a question you'd like to share?
Actually, both. Thank you very much. Very interesting. As someone who was opposed to that particular bill for a number of reasons. First, I'm married to a retired sheriff, and so you can imagine the conversations we had in our home regarding this particular bill. But again, part of it is your comments, and all well intended, and certainly Dr. Ornlicker, his again, this bill was well intended. He brought in some folks from international folks, and then only one place in Philadelphia. And I think the concern was, again, the newness of it was one thing, and that it really hasn't been established. And how do you know what the outcomes are if you don't have one to do the research on? So I appreciate that aspect of it. But one comment that you made was that folks had said that they wouldn't have drugs in their house, but our concern was, or my concern was at the time, they're still getting these drugs somewhere. There's a supply chain problems for everything else we have, but it doesn't seem there's a supply chain issue for illegal drugs. And one of the concerns that many of us had were, where are they still going to get these drugs? They're still going to be in their home, and they're going to take them to this facility. There's still no monitoring of what drugs they're taking. And that was some of our concerns, to watch folks sit there and potentially overdose with an illegal drug that they have. These aren't prescribed drugs from a provider such as myself. These are drugs that are bought illegally on the street from some, pusher from who knows where, and what these things are laced with. And so I have significant concerns regarding that aspect of it. Yes, I certainly hear and appreciate what you're trying to do for the people that are the users, but there's this whole pyramid effect of this and the whole other concerns. And so happy to continue the conversation next cycle around regarding some of the things that you heard testify, and the concern that many of us had regarding these type of facilities. So that I just want to kind of go on record with that comment.
appreciate you highlighting these concerns from the last legislative session. I think it's important, especially in the interim, that we can work through some of those if this bill is going to make it back into the legislative session. I saw both Dr. Wagner and Ms. Lee raise their hand in response. If you guys would like to trade off in response, we do have a little bit of a time constraint here, so about 2 minutes, if you may.
Lisa Lee, for the record, I will be very quick. Dr. Titus, as you were speaking about that, the first thing that came to my mind was this is an opportunity for additional surveillance to really see what people are taking. And there's an opportunity, and it was suggested much earlier in the day about checking syringes. And Track B is actually doing that using technology down in Las Vegas, but this would provide an additional opportunity to really see what kind of contaminants, because certainly fentanyl is one of many. We're also seeing trank dope, which has, oh my gosh, Carla, what is it? What is that? It's too late in the day for me to, it's a benzodiazepine intended for animals that's being found in some parts of the country.
Ketamine?
I don't know. I can't remember.
Ketamine probably, huh? Isn't it ketamine?
No, it's not ketamine. And I'll get back to you with that, Dr. Titus, because I'll probably remember shortly. But there are other contaminants, and I think that this offers an additional space in which to really get that ground level surveillance.
Carla Wagner, for the record, just very quickly, Dr. Titus, I think what you're saying is exactly right, that there is no quality control in terms of drugs bought on the street. People don't know what they're getting, and that is exactly the argument for a space where people can use under medical supervision. Because you don't know, and we can't control that side of it, but we can control this side of it.
Thank you so much. I do not see any other questions coming up from my committee. I'd like to thank you both for your continued work in this area and for the presentation on this issue. And we hope to hear from you again as we move through this interim and kind of vet out some more of this issue area. With that, we're going to move on to our next agenda item, which is agenda item 12. I'm pretty sure it's 12. Behavioral and mental health insurance payment. Thank you. I'm getting a nod from staff. Payment parity and the national landscape. And today we have Tim Clement with us, the Director of Legislative Development from the American Psychiatric Association, to present on this particular issue. Please go ahead when you are ready.
Okay, well, thank you very much, Chair Peters. And just before I start, what's my time frame here? I don't want to go over any limits here.
I appreciate you asking us about, we have approximately 30 minutes set aside for your presentation, and then we have another 10 minutes set aside for questions and answers.
Okay, well, to everyone's delight, I don't think I'll take the entire 30 minutes. I know it's been a long day. So I'm going to share my screen here and bring up my slides. Okay, can everyone see my slides all right? Thumbs up, Chair Peters, if you can see them.
Yep.
All right.
You can see it.
Okay, so my name is Tim Clement. I'm with the American Psychiatric Association, and I'm going to give a presentation today about mental health parity. And don't let the phrase detract from the fact it's mental health and substance use disorder parity. It's just as much about substance use disorders as it's about mental health. And also, because there was a request, I'm going to just throw in just a little bit of information about telehealth at the very end. Just a few slides, but the gist of this will be about mental health parity. Okay, so what is mental health parity? And as I said, substance use disorder is just as much a part of it. Well, the basics are it's a very simple concept. It's that insurance coverage for mental health and addiction treatment should be no more restrictive than coverage for other medical care. That's it. Very simple. And it doesn't mean that treatment has to be the same. No. It's just the insurance practices for mental health and addiction cannot be more restrictive than what they are for other medical care. All right. So given that, why are there state and that's a simple concept. So why are there state and federal laws about parity? Well, historically, insurance coverage for mental health and addiction was much more restrictive than coverage for other medical care. And what this looked like is it was very common to see more expensive co-pays and co-insurance for mental health and addiction care, separate deductibles for mental health care, for medical care, then a separate deductible for mental health care, then a separate deductible for substance use disorder care. And those deductibles for mental health and addiction would be much higher and harder to reach than they were for medical. Hard limits on inpatient stays, 20 visits per year, then you're on 20 days per year, then you're on your own. 30 visits per year for outpatient care, then that's it. That's all you get. So then in the late 90s and early 2000s, states started passing what, as you see the quotes there, state parity laws. However, many of these laws were well below the standard of actual parity, as in they still made it explicitly legal to have more restrictive mental health and addiction coverage. In fact, some of these state laws actually codified more restrictive insurance coverage for mental health and addiction. But what these laws generally would do is they'd establish a minimum number of inpatient days and outpatient visits. So you get at least 45 days in an inpatient facility, at least 60 visits outpatient, whatever. I mean, they vary greatly by state. They established annual and lifetime dollar minimums. So you got to provide at least $5,000 worth of care coverage for each year. Or they would establish a list of serious mental illnesses that must be covered, and then other conditions were considered optional. So that was the landscape for a good 20 plus years or so. States, passing a patchwork of laws, and of course, states can't do anything about those large employer-sponsored plans that aren't regulated by state regulators. So states could do a little bit, and they have been, but it was a patchwork. So then in 2008. President Bush signed the Mental Health Parity and Addiction Equity Act into law. That's what we call the Federal Parity Law. This was October 2008, sponsored by Patrick Kennedy, Democrat. So you got a dynastic Republican family signing the law, dynastic Democratic family sponsoring the law, very bipartisan. And it's been bipartisan throughout. So what the federal law is, it supersedes most of those state mental health and addiction coverage laws. So for example, many state laws, not Nevada, still have some provisions on the books that are that codify some of that more restrictive care. Those no longer have effect because of the federal law. So the federal parity law is basically, it sets the floor. Anything that's lower than what's in the federal law, it's superseded. However, states can go beyond the federal law or help improve its implementation, like you did in Nevada last year with AB 181. We'll talk a little bit more about what states have been doing. Okay, but there's problems still. The concept is simple, but the federal parity law is very complex. And I warn you, do not actually read what's written there, that block of words. It's got the terms processes, strategies, evidentiary standards, or factors, and then it gets repeated again later in the same block. Don't read it. It's incredibly complex. And part of that is because healthcare is very complex. And that's because of this unfortunate reality of how complex the law is. There's been problems with compliance. And most of those relate to the insurer's managed care practices, how they manage the benefits, prior authorization, other utilization review, like concurrent review, retrospective review, step therapy, how they design their formularies, provider network design, reimbursement rate setting. The law doesn't require that reimbursement rates have to be the same, but how you go about setting those reimbursement rates has to be comparable and no more stringent. So anyway, that block of words above sets the rules for insurers' managed care practices. So there's because of how complex this is, there have been some problems. Well, how do we know there are problems? Well, back in 2017, thanks to grant funding from the federal government or the Trump administration, a number of state insurance departments began looking into insurance compliance with the federal parity law. So 2017-18, about 20 states got this federal grant money and started digging into it. And basically every examination found that insurers were not compliant with the law as it related to those managed care practices we just talked about. I mean, and there's a saying among state insurance regulators that have looked into this: if you look, you will find problems. And it's not because of malfeasance. It's not because it's just, the insurance industry, they've struggled with the complexity, and they might not have taken it quite as seriously as they needed to until recent years when there's been a great deal of action. And also federal regulators, when they were looking, the United States Department of Labor, when they were looking, they were finding problems too. Okay. So then, beginning in 2018, states started to take action, passing legislation that required greater transparency and accountability from insurers in terms of compliance. So they're requiring insurers to do these compliance analyses and submit them to state regulators. And you see here, we're up to 17 states, with Nevada joining the party last year. We expect to see several more this year. And as I said, it requires the insurers to do these comparative analyses, demonstrating compliance with the federal law. And the format of those 17 state laws, the format's the same in all 17 states. And then after they saw this happen, Congress took action too. So in December of 2020, Congress amended the Federal Parity Law by adding language that was identical to what was in all those state laws. And so that what this ended up doing is it cleared the deck. So for all 50 states now, in every state, every insurer and every group health plan in America, including those that states can't regulate, they have to do these analyses and they must make them available to federal and state regulators upon request. And the amendments also require that the federal regulators, they have to request a certain number of analyses every year. But you still, states, the reason this happened in December 2020, Nevada passed AB 181 in 2021, but that's because you need the state legislation to formalize this process to make sure that these analyses are actually submitted and looked at by state regulators. Okay, so a good question is, how do we go from 5 years ago today, 0 states and the federal government required transparency to this extent? Now everyone, every insurer in America and every group health plan has to be transparent in this uniform fashion. Well, as you know, many people are dying every day from overdoses and suicides, and that statistic there, nearly 400 Americans each day, that's wrong. CDC just issued updated overdose data, and that's now up to 410 Americans die every day from an overdose or suicide. When I first started saying that in 2016, it was 245 Americans die every day. So we've gotten worse by about 155 people in the last 6 years. So a terrible crisis 6 years ago has gotten that much worse. So things are really bad, and of course a lot of it has to do with the fentanyl. Okay, another reason why laws pass so fast is usually when you have health insurance and you're really sick, insurance covers the treatment you need to survive and get better. That's a pretty common commitment. You're sick and you might die, like you have a opioid use disorder and you overdose and then you get naloxone, you're revived, you go to inpatient treatment. The physician or the provider say you need to be there for another 3, 4, 5, 6 days. And the insurer says no, you don't. We're going to contradict the recommendations of the medical, the healthcare professionals and say you don't need it. That's commonplace in behavioral healthcare. So for other medical conditions, when you're sick and you're going to die potentially, insurance covers the treatment you need to get better and not die. When it comes to mental health and addiction, that often does not seem to be the case. And also another reason these laws pass so fast, the federal laws fundamentally comparative. How could an insurer know that it complies with this law unless it was doing comparative analyses? You can't. There's no way you could know whether you comply with this law without doing comparative analyses. And state legislatures and Congress found this argument very persuasive, and that's why it happened. Okay, so all this actions happened. There's a lot of stuff has happened at the state level over the last 4 years. A lot of stuff happened in Congress. The amendments to the law also required the federal agencies to submit a report to Congress every year about what they find when they look at these analyses. So they just released their first report a few weeks ago. And it focused on what they found in the comparative analyses they reviewed, and not a single health plan or insurer was able to submit sufficient information initially. And so these are the very same analyses that are going to be coming into the Division of Insurance and and also for Medicaid here in Nevada this year. So just keep that in mind when we think about those reports that are going to come in here in Nevada. When they gave them to the federal government, all of them were not good enough initially. And then when they asked for more information and got information, they found all kinds of violations. It was a really bad report. In fact, that's something that you have my contact information at the end. If you email me, I can send you the report. It's worth a read. Anyway, what it shows is there's still a lot of work to do. The reason a lot of these laws passed is because we had a feeling that there wasn't full compliance with the law, and now it's been confirmed that's true. We do have problems. So there's work to be done, and a lot of that has to happen, both the legislative level, but also the regulatory level. So what are states doing now? Well, obviously, some states are pursuing legislation similar to AB 181. But big deal, big takeaway. Here's something I think is the most important about what are states doing? And I know this falls outside of the legislative arena, but 32 states have joined the Parity Working Group of the National Association of Insurance Commissioners since 2020. And actually, it's 33 states. I just checked a few minutes ago, and it's actually 33, and another one just joined. So this is state insurance regulators, and they meet regularly, and they share best practices about what they're doing on parity. So some really good states that have been doing stuff on parity, like Illinois has been doing a good job, Texas has been doing a good job, Pennsylvania is doing a good job, Oklahoma's getting really good. These guys, they have a lot of good things to tell their regulator colleagues. And the National Association of Insurance Commissioners, they meet all the time. They meet 3 times a year in person. I always go there. And so it's a great opportunity to be part of this parity working group. Now, unfortunately, and I don't mean this as a dig, I'd say it's an opportunity here. The Nevada Division of Insurance has not yet joined. So I think that'd be fabulous if the Division of Insurance joined that working group. I think they'd learn a lot. These regulators that are part of that group, they really want to share what they know with their colleagues. And so I think that'd be a great thing for the division to join that group. And the legislative angle, some are providing funding for insurance departments to designate a full-time parity specialist. So in Arizona, they have a Dr. Lynette Hennigan, who has been hired and has been on the job now for a year and a half. When they passed their parity legislation in 2020, they funded a full-time person for a number of years to be on top of parity. And really for a department to do what it needs to do in terms of parity compliance and implementation, you probably do need to have that full-time person. Otherwise, it's so complicated that if you have other things you need to do, you got to worry about auto insurance, flood, casualty, homeowners, you're probably not going to get on top of this complicated law. That's why it's a smart thing to do to fund a full-time person. And also right now there's congressional legislation that would actually send grant funding to states to add staff to do some of this work. I'm not sure how the status of that will be, but there's something that's out there. Okay, what else are states doing on mental health coverage? Well, a few states passed legislation in 2021 that requires insurers to rely on nonprofit specialty society criteria when determining if mental health or addiction care is medically necessary. So for example, in these 3 states, and you see them listed below, California, Illinois, and Oregon, if you're making substance use disorder medical necessity determinations, level of care placement, you have to follow the criteria of the American Society of Addiction Medicine. You can't use your own in-house criteria that you've really designed just to maximize, to suppress costs. And the reason this is happening is because a major court case, the Witt v. United Behavioral Health, found that a major insurer was making decisions about mental health and substance disorder care on in-house criteria that was specifically designed to suppress costs. For instance, when the medical team, the behavioral health medical team, wanted to go to the American Society of Addiction Medicine criteria, they wanted to adopt that, they were overruled by the corporate office because of the presumed cost that might be. So following the best that medicine and science has to offer, that was not what United Behavioral Health wanted to do. They wanted to keep costs down at a certain level, and that leads to poorer care and more people dying. So this is something that a few states have done, like I mentioned, California, Illinois, and Oregon. And also Georgia is pursuing a lighter version of that this year. So it's something that, it's a pretty comprehensive piece of legislation. And it's model legislation that exists and is out there that's created by an organization known as the Kennedy Forum. Kennedy Forum is run by former Congressman Patrick Kennedy, who was the sponsor of the Mental Health Parity and Addiction Equity Act, the current federal parity law. Okay, so just a real brief, I want to wrap up here with just a little bit on telehealth and insurance coverage. This is not about the delivery of this is about insurance coverage. This is a separate issue, but it's somewhat related because a lot of telehealth happens in the behavioral health realm. So anyway, in telehealth coverage, insurance coverage legislation, this is not a new thing. This is something that's been going on for many, many years. And before the pandemic, the main issues pursued were 1, insurers should cover telehealth. 2, the reimbursement would be the same rate as in person. And then 3, efforts to cover what's called asynchronous telehealth. What that means is the patient isn't there when the telehealth occurs. So how's that possible? Well, what that could look like is a patient comes into a primary care physician's office. The primary care physician asks him maybe a depression screening, writes down his answers or records the encounter, and asks some questions about potential depression, anxiety, then stores it and then sends it to a psychiatrist who looks at it, say, 5 hours later, and then renders, their determination of what, diagnosis the patient might have. So anyway, that's what was going on before the pandemic. And if you want to know more about telehealth, here's a great resource, the Center for Connected Health Policy. You see that link there. It's in the slides. But just search Center for Connected Health Policy. You'll see what's happening all over the country when it comes to telehealth, and not just coverage, but also all kinds of other things related to telehealth. That's the best resource in America on telehealth. So if you want to know a lot about telehealth, go start there. cchpca.org. Okay, but telehealth during the pandemic, and hopefully we do get to a beyond the pandemic. Beginning in March of 2020, telehealth came to the forefront of everyone's mind. We all know this. Everyone was familiar with telehealth by the spring of 2020. Legislative efforts to expand telehealth focused on the previous goals that we just talked about, but also coverage of audio-only telehealth under certain circumstances. It's always, you want to see that patient, but sometimes it's not possible because of broadband, or it might not be medically advisable due to maybe symptoms of psychosis or something like that, and the person will not get on camera. Prohibiting insurers from requiring that only a certain technology platform or vendor be used. That can be very, very disruptive to care, because if you have 6, 7, 8 insurers and they all have a different platform, they all have a different vendor, that's going to be a lot of money for providers to get all of those things up and running. So that's something that, trying to prohibit that. Prohibiting utilization review that's in place for telehealth, but they don't do it for in person. So you have to do prior authorization for telehealth visit, but you don't have to do prior authorization for that same visit if you were in person. And then allowing for a little more flexibility where the patient and provider can be located during the telehealth site, which is known as the originating site and the distant site. And very last slide here of content, I'll give my contact information on the next slide. We at the American Psychiatric Association, we actually created model legislation on insurance coverage of telehealth. That's something I worked with our telehealth committee and put together the model legislation, and addresses the issues described previously. A few other bells and whistles. You can go to that link if you wanna look more or search into Google American Psychiatric Association model telehealth legislation. Now, 2 good case studies in enacting this legislation are Georgia and Oklahoma. So in 2021, Georgia passed HB 307, which has most of what's in that model legislation, and so did Oklahoma with SB 674. So it shows that that model legislation definitely has some opportunities to pass and go somewhere. Okay, so with that, I am going to post my contact information, Tim Clement, Director of Legislative Development, tclement@psych.org. If you have any questions that you want to go into great detail about anything but what I went over, whether it's mental health parity or telehealth, please send me an email. And with that, I am going to stop sharing my screen.
Thank you so much. That was informative and helpful. Nice to see that there's some bipartisan effort across the country in this area. Looking forward to seeing what we've come up with in Nevada to do this. Are there any questions from the committee? I have questions that came up, but mine are more directed for our department or a division of insurance rather than for you. But we really appreciate your time today. And I will have some folks follow up with you. I'd like to get my hands on that report you were talking about. So I'll have staff email you for that if they can't find it online.
Okay, well, thank you very much, Chair Peters.
Thank you. Cool. So we're going to move on to our next agenda item 13. This is the overview of and policy considerations related to Assembly Bill 181, just referenced in that last presentation. This bill requires certain health insurers to demonstrate mental health parity, payment parity, and addiction equity compliance. We have Nick Stosic, the Deputy Commissioner with the Division of Insurance, on today to tell us a little bit about this bill and how things are going.
Thank you, Chair Peters. I appreciate it. Can you all see my screen? Is it being shared? There we go. I think it's shared now.
There it is. Great. Thank you.
Very good. Well, Chair Peters and members of the committee, I appreciate the opportunity to be here. As you indicated, I'm Nick Stosic. I'm a Deputy Commissioner with the Division of Insurance. You'll also see the name of Jeremy Gladstone, who's effectively our subject matter expert on network adequacy and mental health parity. And unfortunately, he had to leave the office at 2:30. So I will do the best I can to answer questions, but if there are any I can't, I will be sure and get back to you as quickly as we can. Also, I appreciate Mr. Clement's presentation, and being the last presentation today, you'll be glad to know I'll be able to cut out some of my slides because he covered some of the subjects that I would have been covering. And I'll also just give you an update since he mentioned us in his presentation. Although we're not a member of the Mental Health Parity working group at the National Association of Insurance Commissioners, our staff does participate as a part of every one of those committee meetings. So it's something that we're up on the subject. We're just not an official member of that committee at this point. So I was asked today to present on AB 181. And as Mr. Clements mentioned, it was passed in 2021. And part of the language of that bill is directly related to the federal Paul Wellstone and Pete Domenici Mental Health Parity and Addiction Equity Act of 2008, which is also known as MAPIA. And again, Mr. Clements gave you a pretty good overview on what that particular bill covered. AB 181 amends NRS 687B 404 to require the Commissioner of Insurance to perform a data request on or before July 1st of each year from insurers or organizations providing health care to solicit information necessary to evaluate their compliance with the Mental Health Parity Act. The information needs to be provided to the division by October 1st of each year, and then by the end of the year, the Commissioner is required to summarize and provide a report to the Patient Protection Commission, the Governor, and the Director of the LCB by December 31st of each year. AB 181 was effective on January 1st of 2022. So our first data call will occur prior to this July, and our report compiling the information will be submitted by the end of this year. This particular slide I can pretty much pass because it's really telling you about the Appropriations Consolidated Act that Mr. Clements addressed and what are the requirements for carriers to start to provide a really a comparative analysis on the non-quantitative treatment limitations. And this particular bill was effective on February 10th of 2021. So the insurers had their first go around of producing those reports, as Mr. Clements mentioned, and we're looking forward to, again, having that occur and being given to us this coming year. So AB 181 allows for insurers or other organizations to file a copy of that federal report in lieu of the data that the Commissioner is asking for. However, the bill does allow the Commissioner to request supplemental information beyond this report to determine whether the insurer or other organization is in compliance with federal law. And I assume this first year will kind of be interesting for us to see what type of information is provided. And based on that, I would assume in future years, we'll be probably asking for a more additional information that they're going to be filing. So up until now, to determine compliance with federal mental health parity laws, the Nevada Division of Insurance conducts annual reviews of health benefit plans sold in our state. The division reviews plan documents and plan designs, including coverages, drug formularies, network designs, and other aspects of the plan. And as part of this review, we look for red flags, which may indicate non-compliance with MAPIA. And then every carrier is required to attest, as you'll see from this slide, to any differences they have in annual or lifetime limits. Do their contracts provide any mental health or substance abuse treatment limitations, the availability of their plan information, and their internal claims appeals and external review processes. So that's what they currently are required to do. When we go forward and get to see the comparative analysis, they'll also be giving additional information on things like prior authorization requirements, concurrent reviews for in-network and out-of-network inpatient and outpatient services, standards for provider admissions to participate in networks, including reimbursement rates, formulary designs for prescription drugs, and step therapy protocols. So we will obviously be getting a lot more information this year than we've been receiving in the past. Okay, so one thing I wanted to share with you, Chair Peters, and the rest of the committee members, is the Division of Insurance was recently awarded federal funds under the Cycle 2 State Flexibility Grant. And we'll be using those funds to contract out the research and development of procedures and tools that can be used by our division staff to conduct MAPIA compliance reviews and ensure a consistent and thorough review is done on all health insurance products. We intend to use these federal funds to conduct an assessment of the division's current procedures and tools, research what other states are doing to address MAPIA compliance, and develop procedures and tools that can be used to do a more rigorous review for MAPIA. It will be going out to bid this year, so I'm assuming that it'll be later in this year we'll finally be starting to access those grant funds and begin this review. And then lastly, I did want to review 2 Nevada statutes which really still would not be in compliance with current federal MAPIA law. Mr. Clement had addressed this issue that sometimes there's some obsolete limits that are put in Nevada law, actually in NRS 689A 046 and 687C 167. We currently have limits that, for example, have a $1,500 per calendar year for the treatment of withdrawal from drugs and alcohol, $9,000 for inpatient treatment, and $2,500 for outpatient counseling. So again, separate from federal law, these are the requirements that technically a carrier would be able to follow and be in compliance with state law. The drug and alcohol treatment limits were added to Nevada statutes during the 1985 session, so it's been quite a while. And this is an area that the committee may want to consider removing these limits from those 2 statutes and pointing to federal law to ensure that carriers are in compliance with MAPIA. Making this type of change would not create a new mandated benefit for the state, since it would be altering state law to match federal law. And with that, that is the end of my remarks, and I am more than happy to answer any questions the best of my ability.
Thank you so much. Really, really grateful for the update. I was really invested in this piece of legislation last session, so it's nice to know it's being applied, and I'm looking forward to our first and comparative analysis or assessment. It's awesome. Okay, I had a couple of questions, but I want to ask the committee, do you have questions before I jump in? Not seeing any coming up right away, I'm going to go ahead and ask mine. The first one has to do with, and you kind of addressed part of it, becoming a part of that National Association of Insurance Commissioners Parity Working Group. You said participate, but not as a member. What does it take to become a member, and is there something that we can do to support that?
Well, Chair Peters, really to become a member is just probably a matter of requesting to do that. There are about 200 different NAIC committees, and so we are members of, I think, about 50 committees right now. So we kind of spread our membership around, but the very important committees we are not members of, we still attend every meeting. So we're still involved in the discussions. If you would like, we would be happy to go forward and get formal membership, but I can assure you that we are attending all the meetings as well, and we're notified anytime a meeting is being held.
Of course, I would like for you to just do what's best for Nevada. And if that is making sure that you're in the right room at the right time, then that is what that is. But if there are benefits to being on that working group, such as sharing of information and other parts and pieces of making sure we're doing a comparative analysis that is whole, that would be great. But keep us posted. If there's anything
Sure.
to let me know on that. And I was wondering if there was a membership fee or something that we needed to make sure.
No, there's not. And being a working group, they are actually working on potential legislation, et cetera. So being a member of the working group would just put you more active in the additional functions of working to do that, as opposed to be somebody that's listening in and providing input. So if that makes sense, it's an actual working group that is trying to develop potentially different models for the MAPIA.
Great. I think that leads into one of my my next question, which is related to the potential position funding that Mr. Clement mentioned. There's a grant fund that some folks are using specifically for this comparative analysis and data collection position. And I was wondering if you guys have applied for that grant, or and if not, if there's a reason.
So yeah, that was a part of what I was talking about when I had mentioned that we had been given Cycle 2 state flexibility grants. And so that as a part of that grant, we are going to be hiring, contracting out to have the process on researching development of procedures and tools from OPID being done. So we have been awarded that grant. And again, the funds are going to be specific to this particular subject.
And so you're contracting out that service to do the initial determination of what your process is going to look like. And when you imagine you'll come back to us with maybe we need more staff, maybe we need more authority. Do you think you'll come back to us with some of those recommendations?
Yeah, I would have to say, Chair Peters, I really expect that once we see what we find from this particular grant, and once we go through the first year of receiving these comparative analysis and seeing how involved the amount of work is, we're going to have a much better understanding if it's something that current staff can handle, or if we really would need an additional position in order to do an adequate job. Because I'm just not sure, I'm not envisioning it's something that would be a year-round full-time position. So that's why, it's going to come in at one part of the year, be analyzed over about a 3-month period. And so that's one of those things that I think we will have more information down the road on what we're going to need in terms of staffing. Great.
Keep us posted on that piece. I have one last piece, and hopefully it's a quick response. I don't intend this to be a large-based conversation on, but one of the points mentioned by Mr. Clement was that the bill from the federal bill from February 2021 authorized states to request information from all payer types, including the self-funded plans. And I'm curious if you guys believe you have the authority to ask for that information, despite the fact that we can't regulate it, or if that is something that we would have to consider through legislation.
That's one of those questions, Chair, that I would have to look into. Generally, since we have no regulatory authority over providers, I would say typically that's not something we would be able to do. And again, if it's granted under federal law, that also doesn't necessarily give the states that regulatory authority, but that's an issue we're more than happy to research and find out more what's contained.
I would appreciate that and some follow-up on it. Not that we want to regulate them, but it's important that we can, when we do a comparative analysis on things like this, that we are comparing across the board. In my mind, having parity and consistency of care, or that continuity of care is really important, whether you're bouncing between Medicaid and PEB or Silver State plan and a private plan. So especially for mental health care and behavioral health care, wanting to make sure that our comparative analysis is consistent across the board would be really great. So let me know what you find on that.
Absolutely. We'll do that.
All right, any other questions from the committee before we move on to our last item on the agenda? Seeing none, thank you so much, Mr. Stosic. We appreciate your time here today and your efforts on this bill implementation. Look forward to your report in December.
Very good. Thank you so much.
All right. So we had agenda item 14 up next, but we went over that earlier today when we had Dr. Kearns with us. So our last item on the agenda is public comment. We're going to take a short break to allow people to call in under public comment. Again, the information for calling in is on the agenda today. We're going to take like a 2-minute break here real quick while we get people on the line. There's a little bit of a delay, and then we will hop back on here in 2 minutes at approximately 3 o'clock. All right, it's 3 o'clock. If we can have members turn their cameras back on. And APS, I'm going to take a little statement and then ask you to pull up the first person on the line for public comment. Please remember to call in for public comment to clearly state and spell your name and limit your comment to 2 minutes today. Staff will be timing each speaker during public comment to ensure everyone is given a fair opportunity to speak. Staff in our broadcast production services, please add the first caller to the public comment with public comment to the meeting.
Thank you so much, Chair Peters, and your public comment line is open and working. However, there are no callers at this time.
Well, that's great. Thank you so much. I just want to mention that our next meeting will be held on March 24th at 9 a.m. Thank you all for your flexibility on that. I had some travel schedule movement for March 23rd, so I'm glad we were able to move that to a time when we can all be there. And I'm going to go ahead and adjourn our meeting unless there are some other comments from the members.
Madam Chair, I just want to tell you, a great, thorough presentation. Appreciate you putting all this together, the various opinions and all that you've covered. So well done. Thank you.
Thank you for that feedback. I really want to thank staff. Staff worked really hard with our Department of Health and Human Services to come up with some great solutions and options and folks to come and present today. So I think we're on heading the right direction on issues related to this behavioral and mental health care area in Nevada. So thank you for that feedback, and thank you so much, staff, for all of your effort into this as well. All right, with that, we will adjourn. Have a good afternoon, y'all.